When to enroll into Medicare. You'll learn about Medicare's financial risk, and we'll show you how to protect yourself from both penalties and hefty medical bills. We're going to break down the key differences between Medicare Advantage plans and Medicare supplemental plans, and I'll show you how you can easily decide which is best for you. Plus, you'll learn how to select the best prescription drug plan and reduce your medication cost. By the end of this video, I can promise you that you'll have a clearer understanding of your Medicare options, you'll eliminate any Medicare stress, and you'll know exactly which plan suits you best. All right, so let's get started. The first thing that I want to address is how Medicare eligibility is actually determined. Well, you'll see here that for most people, and this would be about 85% of the population, eligibility begins at 65. But there's one requirement, and that is that we have to have 40 quarters of Medicare taxes paid in the system. Now, most of you watching this have probably 30 or 40 years already paid in, but we have to have at least 40 quarters, which is 10 years worth of work paid into Medicare. Now, you'll notice here that those 40 quarters could be of your own, and that's the norm. It's your own 40 quarters, your own work record. But sometimes people don't have 40 quarters, and we get those from someone else, and that could be a present spouse. Here's the rules. If you don't have your own 40 quarters, you get it from a spouse. That spouse has to be at least 62 years old. They do not have to be taking Social Security. They just have to be eligible. And you have to be married to them for 1 year or longer, and it has to be proved with a marriage license. All right, now sometimes divorces happen, we know that. And so some people actually can get their 40 quarters from an ex-spouse. Now the rules are different. That previous marriage had to last for at least 10 years or longer. You could not have remarried prior to the age of 60. If you remarried prior to the age of 60, you cannot go back to the ex-spouse. But if you remarried after 60, or you remarried in that second marriage ended in death or divorce, then you can go back to the ex-spouse. Now again, that ex-spouse does have to be at least 62 years, had to be married 10 years or longer, and that has to be proved with the divorce decree. Okay, now notice also this. Some people, about 15% of the Medicare population, actually will come into Medicare a different way beyond age, and that is they come in because of, notice, Social Security disability. They were diagnosed with an emotional or a physical disability, and they receive those Social Security disability payments. And then on the 25th month of having received those payments, then their Medicare A and B will begin. All right, now secondly, I want to talk about deciding when to enroll into Medicare, because you want to start Medicare at the right time. There's problems if you do not. And so there's actually 5 groups of people that must enroll into Medicare A and B at 65. You have no other viable option. So the first one would be any of you who are no longer working, or your spouse is no longer working, meaning you do not have an employer-provided plan available to you. The second group of people is actually anyone that you'll notice here that's on COBRA insurance, but also watch COBRA insurance, TRICARE insurance. TRICARE is for those people that retired from the military, as well as look at small employer insurance plans. And small employer to Medicare is a group that has 19 or less employees. And the payroll is 19 employees or less, full-time, part-time, doesn't matter, 19 or less, then these 3 groups of people have to go on Medicare at 65. And they have to go on really for the same reason, because what happens is if you have COBRA insurance at 65, COBRA, if you keep it, moves to the second payer position. Same thing with TRICARE, moves to the second payer position, and the small employer does as well. So if they move to the second payer position and that's all they have to pay, you have to enroll in Medicare to put Medicare into that first payer position. And if you do not do that, then you become the first payer. And so many people are not aware of this. So again, you've got to go on at 65, any of those groups. And then lastly, anyone that's covered by what would be an Affordable Care Act plan. They went through the healthcare exchange to get that plan. What happens with ACA plans, technically you could keep them beyond 65, but the problem is all the financial benefits of those go away. No longer are you going to get tax subsidies. You're not going to get a reduced premium. You're not going to get any cost sharing paid by the government. In other words, you would pay full premium, full deductible, full cost sharing, and so there's no financial reason to stay on an ACA plan once you're Medicare eligible. All right, now I want to talk about enrolling, because you have to enroll the proper process, of course, at the right time. So let's just deal with these people first. Those that are, notice, that are not required. We talked about 5 groups that are, but this group of people are not required to enroll into A and B at 65. But notice what we put in here, but they still should. Well, why would we say that? Well, here's why. This is someone that doesn't have to enroll in a Medicare A and B because they're on a large employer plan. They or their spouse covered by a plan that has 20 employees or more on the payroll, you don't have to do anything with Medicare A or B. But we're saying, but you should. Well, why is that? Well, because you took the time to compare your Medicare option with that employer plan. And sometimes employer plans are great, and sometimes they're mediocre or even lousy. So what we suggest you do, even though you don't have to go on Medicare, see if Medicare may be a better option. All you have to do is look at the premium. What's it cost you to be on the plan? Do you have a deductible, and do you meet that? Sometimes deductibles are high, $2,500 a year, and you meet that deductible. And what's the annual max out of pocket? So if you got cancer, some serious heart issue, or some other health issue, what would you spend in that year? Sometimes it's $10,000, $15,000, and then your medication coverage as well. So look at those different aspects of the plan, compare it to your Medicare option. And sometimes Medicare makes sense, makes more sense than what the employer plan is offering you. And if it does, then go on Medicare. It's fine to do that. The employer must let you move to Medicare at 65. They cannot make you stay on the group plan. Okay, so that's those of you, at least do the comparison to see if Medicare makes financial sense. Now, the third group here I want to address are those that are, again, not required to enroll in Medicare A and B, and you should not enroll. Well, why is that? Well, again, you're on a large employer plan, don't have to do anything with A or B, and you did the comparison, and your group plan is a good group plan. The premium's low, the coverage is great, you love the network, you're very, very happy with the plan, then stay on the plan. You can pick up Medicare at a later date, no problem. But here's what I want you to also consider when you look at this decision going on Medicare, other family members that may be covered by the group plan, because we wouldn't want anyone to go on Medicare if they don't have to, 20 or more in the group, employee payroll. And if you want a Medicare, then your other family members are going to be affected by that decision. You may have a spouse that's younger, doesn't have any other insurance options, children covered age 26. Maybe they don't have other options as well. So again, don't go on Medicare if someone else is going to be hurt by that plan. Even though you could, you should stay right where you are. I have one caution now for those of you that are on large employer plans. You will hear people say you have to enroll into Medicare A only. If you keep working, you stay on the group plan, you still have to take A, and if you don't take A, you'll be penalized. And I want you to know that's not true. It's not true. The only people that ever pay for a penalty on A are those people that have to buy A. And that's only 1% of the population. If you have 40 quarters, you or your spouse, your premium for Part A is zero your whole life, no matter when you take it. So you do not have to enroll into Medicare A only if you continue to work. Here's why it matters. Because if you're covered by a group plan, and it's a high deductible health plan, and you are contributing to an HSA, a health savings account. If you enroll into A only, you can put no new money into your HSA. Now, the money you have in there is yours, but once you enroll into Medicare A only, no new money can go in. I think you just shot yourself in the foot. It's like a healthcare IRA. Money goes in tax deductible, money grows tax deferred, and it's tax exempt if you use it for medical expenses. And so HSAs are wonderful benefits. And so I would encourage you, don't do anything with Medicare. And as long as Medicare A is free, I promise you, you'll not be penalized at all. Okay, now listen, if you don't have an HSA, it is fine to enroll in a Medicare A only. In that position, the group plan, because it's 20 or more, still pays first. Medicare will pay second. Medicare in the second payer position pays no deductibles, will pay no copays, but it could pay coinsurance and may even cover something that your group plan would not cover. So I encourage people, as long as you don't have an HSA, it's fine to take Medicare A only. All right, now let's talk about how to enroll. How are you going to do this process at the right time? Well, first off, there's some of you that are going to be automatically enrolled, nothing you have to do. The Medicare is going to enroll you because you're receiving, notice here, Social Security benefits. So because you're receiving Social Security retirement benefits, they assume that you don't have a group plan available, so they automatically enroll you. And notice what happens. They send you your Medicare A and B card about 100 days before your 65th birth month. 100 days, about 3.5 months, the card's going to show up in the mail. Now listen, if you have to go on Medicare at 65, then you want to keep the card. With those 5 groups of people I talked about, or if you're in a large group and you have lousy insurance at work, then go ahead and keep the card. It's fine. But some of you have good group plans, you or your spouse, and you really don't want to start Medicare yet. So Medicare knows this is going to happen, so they actually make provision for you to delay taking Part B. If you're on Social Security, you have to stay enrolled in Medicare A, but you don't have to take B if you have a group plan 20 or more that's attractive for you. So here's what you do. You turn the card over and they give you the option to delay taking Part B, opt out of B, and you can actually do that by returning the card. Turn the card over. You can sign your name. You can check the box that says, I do not want medical insurance, which is the Part B. And you send it back into them. And then what they'll do, notice, they will mail you a new card, and they will actually enroll you into Medicare A only, and you can pick up B at a later date when you lose that group plan. All right, but if you keep the card and you have a good group plan, 20 or more, what happens? You're going to start paying for your Part B. This year, it's $174.70 a month, and Medicare's in the second payer position. And so, in my opinion, that's really not a good use of your money. All right, so I'd encourage you, return the card if you have a good group plan. Even though they mail it to you, you can opt out of Part B. Now let's talk about those of you that are not on Social Security. You are going to have to actually self-enroll. Nothing is going to happen for you automatically if you're not on Social Security, right? And so those not on Social Security, you have to raise your hand and say you're ready to start your Medicare. Now we start that process by setting up what is called an SSA.gov account. Some people call this a mySSA.gov account. So you need one of those accounts. It will help you with Medicare and different explanation of benefits, Social Security, all those kind of things. So set up this account. It takes about 15 minutes to do so. I like the login ID option. You'll have an email address and a password, and just keep those credentials. And every time you go on and sign in, they'll send you a code. And so it's a very, very secure system. So set that account up. So once we have the mySSA.gov account, then we can enroll into Medicare A and B online. Takes about 10 minutes to do that. If you have any problems with the SSA.gov account or enrolling online, then you can always set up an appointment with a local Social Security office, and they'll walk you through that process. Now, keep this in mind. If you decide to use our company, which we hope you do one day, all you have to do is ask us to help you with this. We'll do all that with you and for you. Delighted to do it, and it'll be done correctly. All right, then lastly, very important to note, we have enrollment timelines. If we're going to start Medicare at 65 or even beyond that, there are certain periods of time where we have to take action. All right, and so this example is someone that has to start Medicare at 65 or is making that choice. And so that is called what we refer to as the initial enrollment period. This has to do with turning your Medicare benefits on at 65. Let me explain what this means and why it matters. So first off, this initial enrollment period, notice, is only for 7 months, and that's it. Okay, 7 months. So those 7 months are always tied to your birth month. You'll notice they're 3 months before your birth month, the month you turn 65, and then 3 months after. That's it. So if we have to start at 65, we must do it during this 7-month window. Now, this example is someone who's born during the month of July. And I'm going to clarify something. This is someone that was born either July 2nd through the 31st. Because if this person is born July 1, this whole time frame moves up a month. Because when you're born on the first day of the month, they start your Medicare benefits as well as Social Security the month prior. So if my birthday is July 1, my eligibility month would be June. So it'd be 3 months before that, month of, and 3 months after. If your birthday is December 1, again, then you'd move it back a month. Your eligibility month would be November. All right, so remember to do that. But if I'm born on the second day thereafter, it's always my birth month. So again, if I enroll in this example, April, May, or June, my Medicare will start in July. But watch this. If I enroll into Medicare during my birth month, they'll put me off for 1 month. They'll put me off to August. If my birthday's in July and I enroll into Medicare in August, they'll put me off till September. September, they'll put me off October. October would be the last month I can enroll, and my Medicare would start in the month of November. And here's my point. Whenever you enroll, whatever month you choose to enroll, will decide when they start your benefits. All right, so that's the initial enrollment period. Now, I want to address about 55% of the population does not start Medicare at 65. Why? They're going to continue to work, or their spouses, and they got a good group plan, right? And so eventually, though, you're going to come into Medicare. You're going to either retire or you find that your group plan is no longer good. Either way, here's what's going to happen. You're coming in after 65. So here's the scenarios. It's for those who didn't start A and B at 65. Why? Because they had a good group plan, 20 or more. Right? Or maybe this group started A only. They didn't have an HSA, and now they're going to retire and pick up B at a later date. So those of you in this category, you're going to enroll using a different enrollment period called the Special Enrollment Period, or the SEP. Now, the key to understanding this eligibility is this. Right here it says employer coverage back to 65. So to come in using the SEP, all you have to do is we have to make sure and prove this, that you've been covered by an employer-provided plan. It could be you or your spouses back to age 65. Now, you may have been on that plan for 30 years, but we have to prove it back to 65. And so the way that we do that, you'll notice here, is with a government form called an L564. L564. That L564 is given to your HR department, and they're the one that are going to verify employment as well as insurance. And again, back to 65. And what I want you to learn from this, if you don't take Medicare at 65 and keep working, and if you ever change jobs, let's say at 66 or 67, be sure that you never have any gaps in coverage. You have to be covered by an employer plan. Not a COBRA plan, but by employer-provided plan. So if there's ever a gap in coverage, you won't be eligible for the SEP. So we tell people if there's ever a gap in coverage, go on Medicare for a month or two. If you get a new job with new coverage, you can always drop your Medicare Part B. So the point is no gaps in coverage back to 65. We prove with the L564. And then we have another form you'll notice here called the 40B. And this 40B form is real simple. And this, what we use it for is to tell Medicare when we want to start our Medicare benefits. So if my group plan ends June 30th, I would put on the form, please begin my Medicare July 1. So we pick the date that we're going to start our Medicare. All right? And so what I want you to also learn is that these two forms are never turned in any sooner than 90 days prior to when you want your coverage to begin. Okay, you don't submit them 4, 5, 6 months in advance. They're not going to process those. So within 90 days, we can begin to submit that paperwork. And again, if you decide to work with us, we'll walk you through this whole process, do all this for you and with you. All right, so that's the SEP. It's a different enrollment period. Hey, just real quickly, now that you have a better understanding of the Medicare enrollment process, you may be ready to do that. And we'd love to help you with it. So there's two ways in which we can. You'll see here on the screen where you can actually schedule a free appointment with one of our licensed agents, or you can call our 800 number. And if you're not ready, that's fine as well. Let's get back to the video. All right, now let's get into the details of Medicare, what it costs and what it covers, and we'll look at some insurance options. So first off, what I'm going to look at is just simply the cost of the Medicare premiums, because everyone's going to be enrolled into Medicare A and B. Everyone's going to do that. So what's it cost to do that? Well, you'll notice here, Part A, for most people, 99% of you, Part A will be zero premium for the rest of your life. Why? You paid at least 40 quarters in, or your spouse did. There's no charge. Now, those that don't have 40 quarters or weren't married to be able to get that, notice if they have 30 to 39 quarters that are logged with the Medicare tax system, they can still get A, but it costs them $278 a month. If they have less than 29 quarters down to zero, it will cost them $505 a month. Okay, so when you pay in through these FICA taxes, Medicare says because you have the 40 quarters, will not charge you for Medicare A. All right, now Part B does have a premium, and this is based upon our income. Now I want to clarify this. The income that they look at is called Modified Adjusted Gross Income. Modified Adjusted Gross, that's MAGI. And that Modified Adjusted Gross Income is a formula that is your AGI. AGI is typically line 11 on your tax return plus line 2A, which is tax-exempt interest. So they take line 11, line 2A, combine that income number together gives you your Modified Adjusted Gross. And that's the number that Medicare uses to determine your Part B premium. Now, when they do this, they always look at 2 years prior. So I'm shooting this video for 2024. If I'm on Medicare in 2024, they're going to look back at 2 years earlier, 2022, Modified Adjusted Gross Income. So 2025, they'll look at 2023. They're always looking back 2 years. All right. And so about 85% of the population pays this $174.70. The reason for that is that 85% of the population is below the thresholds, income thresholds that Medicare sets for Part B. And so those thresholds this year would be this: a single filer, as long as you're below $103,000, a married filing a joint return below $206,000, you're below the threshold, you'll pay $174.70 a month. Comes out of your Social Security check, or they'll bill you for this quarterly, or you can actually set up an auto draft with Medicare before you go on Social Security. They're fine to accept payment in any of those fashions. So we pay $174.70. Now, those of you that are above the thresholds, single above 103, married filing a joint return above 206, you're going to pay extra. Now, there's 5 different levels of surcharges, 5 levels. And so those surcharges are actually given the acronym IRMA. It's an income-related monthly adjustment amount. Income-related monthly adjustment amount. So if you're high income, you're going to have these surcharges that are added to them. And those vary anywhere from about $80 a month to about $500 a month. Okay, and that's for Part B as well as Part D. So they add that to those premiums. Now, there are sometimes people have a life-changing event. The government's looking back 2 years, but maybe you retired a year ago, or you're going to retire this year. Then you can always appeal the IRMAs. You can say, hey, I've had a life-changing event. There's 8 possible events. And if one of those events happened to you, then you can say, stop looking back. I'm going to give you new numbers because I have this life-changing event. And that life-changing event, as long as it's happened in the last 2 years, you can actually use that event for 2 different appeals. The paperwork we use is called an SSA-44. And again, if you work with us, we'll walk you through this entire process. So we want to prepare you. For those of you that are high income, you will pay more for Part B as well as Part D. Now let's talk about the services that are covered by Original Medicare A and B. And that's going to be on the A side, it's called hospital. On the B side, it's called medical. Now, the A side of Medicare is pretty much everything inpatient related. So what's billed through that, you'll notice here, is going to be everything that's inpatient hospital care. So anything the hospital could bill you for. Nursing services, room and board, medications while you're in the hospital, any test the hospital runs, all that is going to be billed through the A of Medicare. Skilled nursing facility, you'll notice. Now, skilled nursing is for someone who's had a stroke, maybe a hip replacement, or they had an injury or an accident and they need some fairly intensive rehab. That's skilled nursing. Medicare A is going to pay those bills. And then you'll notice home health care. This would be a situation where someone needed rehab, but not the intensity of skilled nursing. They were in the hospital first, and they sent them home. So Part A will continue to pay the home health care bills because that claim started on the A side of Medicare. And then lastly, hospice care. Now, hospice would be care that someone is receiving because they've been diagnosed with a terminal illness. The doctor believes there's 6 months or less to live. This is pretty much pain management instead of really treatment. And so when they're on hospice, that will be, again, ran through the A of Medicare. All right, now, I want to draw your attention to one more thing, and that's up the top. When you use your A services, it's referred to as an open access system, which means there's no networks in Original Medicare A and B. You can go to any hospital as long as they take Medicare, any skilled nursing facility as long as they take Original Medicare. All right, so that's the A side. Let's talk now about the B side. Again, the B side is the same way, open access. No networks, go to any doctor, any surgeon, anesthesiologist, any durable medical equipment provider that takes Medicare. Okay, again, no network. What's covered? Everything outpatient. This would be your labs and your MRIs, your cataract surgery, your knee replacements, gallbladder removal, those kinds of things that are done on an outpatient basis paid through Medicare B. Now notice this one. All the physicians and other medical providers that you see are going to be paid through the B of Medicare, all physicians. So this would be those physicians that you go to see in their office, or notice they come to see in the hospital. They're going to be paid by B. This would be the surgeons, anesthesiologists, the hospitalists, the emergency room doctors, all paid through B. So it is the A that takes care of the facility fees, but it's the B that always pays the doctors, whether that's in or outpatient. Home health care, we saw it over here. Why is it here? Well, it's here because this is someone typically had a knee replacement, going home for rehab, and the B is going to pay for those bills because it's after an outpatient situation. And then lastly, this would be durable medical equipment. Someone has sleep apnea, they have a CPAP machine probably. Oxygen equipment, scooters, wheelchairs, walkers, diabetic supplies, all those things that are considered to be a durable medical equipment are going to be paid through the B of Medicare. All right, so that's A and that's B. Let's keep going. Now that we have a clear understanding of how the A and B system works, let's talk about now our different insurance options. You'll notice there's 3 insurance options that you have available to use your Medicare benefits. Now the first one is when someone just says, I'm going to get A and B only and nothing beyond that. Okay, now in my opinion, that is not a good choice. There's simply too much liability, too much risk involved in that one. But they say about 10% of the population will do that. All right. The second option is to do what is referred to as A and B system, but in order to eliminate all the risk or some of the risk, most of the risk, then we actually can get what's called a supplemental plan. And so this A and B only has all kinds of financial liability. I'll show those to you here in just a second. But when someone gets a supplemental plan, what they're doing is they're getting rid of the majority of that liability and they're transferring that to an insurance company. That's a supplemental plan, also called a Medigap policy. Now, when we go with option 2, we have to have a prescription drug plan called a Part D plan for our self-administered medications. A and B cover meds that are professionally administered in the hospital or in an outpatient setting, but for those that we take at home, that has to be a drug plan, a Part D plan. All right. Then our third option is called a replacement plan, or called a Medicare Advantage plan. These are also given the letter C. And so what happens with these replacement plans, I'll tell you about them in a few minutes, but it's basically a private health insurance company that's replacing A and B system for you. And so there's one of 2 ways you can actually get a C plan. You can buy one with an embedded drug plan or one without. Now, I want to clarify this. The only people that can reasonably, wisely get by without a Part D plan would be those that can get their prescriptions elsewhere. And there's three options. If you can get medications to the VA, you can get a C plan without a drug plan, or someone that has TRICARE. TRICARE includes prescription insurance. So if you have TRICARE as an option, or you're retired civil service, you have what's called FEHB, Federal Employee Health Benefits. You're retired from civil service, so you also have an insurance option for medications. So anyone with VA, TRICARE, or FEHB could get, and many people do this, they're pretty attractive, would be a Medicare Advantage without prescription drug plan. Okay. Now, if you are not one of those three categories, you're not going to do that. You want some sort of drug coverage. So with this, we would get a Medicare Advantage plan that includes a prescription drug plan. All right. So I'm going to break down all three of these insurance options. So let's start with A and B only. Now, the reason I said I don't like A and B only because of all the financial liability. Okay. Now, what you're going to notice here is the A side of Medicare, the hospital side, inpatient side, and the B side, medical or the outpatient side, actually has 3 gaps on the A, and we have 3 gaps on the B. These are financial gaps or liabilities. You're responsible for these because Medicare doesn't cover anything 100% other than preventive services. There's always going to be a balance to the bill for the services you receive except preventive. And so on the A side, let's talk about the gaps. The first one is a deductible. This is the A deductible for 2024. This goes up a little bit every year. So this year, if I go to the hospital, it's going to cost me, in the form of a deductible, $1,632. That's all I have to pay for notice up to a 60-day stay. So it doesn't matter whether I'm in 1 day in the hospital, 2, 3, 10, 30, or 60. It doesn't matter. Anything between 1 to 60, all I have to pay is the deductible. Now, this deductible is unique because it's not annual. It's called a benefit period deductible, and it can happen more than once in a year. If someone's hospitalized and then discharged, and for the next 60 days after being discharged, they're still under the same deductible. But if they're not rehospitalized during that 60-day window and they're rehospitalized a couple months later, they go back to the hospital, then they would pay that deductible again. It's not annual, it's tied to a benefit period. All right, now, that's all we have to pay for the first 60 days, which is going to cover, frankly, probably 99% of every situation. But occasionally, people are in the hospital longer than 60 continuous days, and then Medicare begins to charge daily copays. This is month 3, month 4, and month 5. Now, again, in this situation, people are very, very sick, maybe even in a coma in this scenario. But notice, month 3 costs you $408 a day, 12 grand. Month 4 and month 5, $816 a day. Now we're spending close to $25,000 each of those months. Very, very expensive for extended hospital stays. And then the last thing covered on the A side is called skilled nursing facilities. I referred to this earlier. After a stroke, hip replacement, maybe an accident or fall injury, something like that. This is intensive rehab. So here's the rules. Medicare says the first 20 days, they will cover everything as long as you were in the hospital 72 hours or longer prior to going to a skilled nursing facility. Got to be in the hospital 72 hours or longer. If not, they won't pay anything. So as long as we have met that prerequisite, we can go to skilled nursing. They cover everything the first 20 days. After that, we have a daily copay for the next 80 days of $204 a day. They say right now the average patient on Medicare that's in a skilled nursing is there between somewhere about 35 to 40 days. So $3,000 to $4,000 out of pocket. So those are our gaps, your liabilities on the A of Medicare. Let's talk about the B. The B starts with a deductible. This year, 2024, it's actually $240. Now, it's not like that A deductible. Remember, it could happen multiple times a year. This is once a calendar year. So if you start Medicare July 1, that's your deductible for this year. If you start December 1, that's your deductible for this year. They don't prorate it. And then that deductible resets every January. Sometimes it goes up, sometimes it goes down. All right. After we've met that small deductible once in the year, now Medicare is going to take all the bills on this B side that we talked about, and they're going to split them with you. They're going to pay 80%. You're going to pay 20%. So as long as you're seeing a Medicare provider, someone that takes Medicare, and that service is covered by Medicare, then Medicare pays 80% and you pay 20%. We call yours coinsurance. Remember, in health insurance, we have copays and coinsurance. Copay is a flat dollar amount. $5 copay, $50 copay, $204 day copay. Coinsurance is a percentage of the bill. 20% is your responsibility. And then lastly, we see a thing called excess charges. Excess charges can only be charged by doctors. That's it, only physicians. And when they do an excess charge, the doc does it, what they're doing is they're not agreeing under contract to take Medicare approved amounts. They're a non-participating doctor in what we call the assignment system. So the majority of doctors, probably 95% of them, will not add to the bill. They say less than 5% doctors will add to the bill. But when the doctor does, and it's going to happen from time to time for people, especially cancer type situations, when that happens, you have to pay for that. Medicare allows it, but they don't pay any of it. Okay, so that's the third and final gap on the B side of Medicare. So again, we got 3 gaps on the A and 3 gaps on the B. So if someone has A and B only, this is their liability. That's why I'm saying I would not assume it's just too much liability. Quick fact, there's $220 billion in medical debt today. $220 billion. Unpaid hospital bills, doctor bills, $220 billion. And so the second largest holder of that medical debt today are those that are Medicare eligible. And this is primarily this group of people here and others that have high max out-of-pockets on Advantage plans. But the whole point is you don't want that kind of liability. And so the majority of people then will look at those gaps and they will take the gaps, financial liability, and transfer that to an insurance company. And they pay an insurance company a premium to take the most of these gaps away from them. The top 2 plans right now are the G and the N plan. Now, there's 10 possible options, but I would say probably 97, 98% of all people today are getting either the G or the N, so I'm going to focus on that during our limited time here. So the G plan is a plan that will fill in all the gaps for you except the B deductible. So once a year, you would have to meet that B deductible. So the first $240 coming through on this side is going to end up as a bill in your mailbox. After that $240 is paid, you should never see a bill. As long as Medicare pays first, and if you paid the $240, Medicare pays first, and that G plan will fill in all the gaps, okay? And so for people that don't like surprises, they're concerned maybe they had a doctor that charged excess, they want the most comprehensive plan available today, they're selecting the G plan. Now there's another plan. About 30% of all people going on today take what's called the N plan. Again, it's a different letter, so it's a different type of policy, different amount of coverage. What it covers is 4 of the 6 gaps, and it has some copays. But notice, the N plan will not pay the B deductible, just like the G did not, but N plan will not pay excess if and when it occurs. Again, low probability of that, less than 5% of doctors do it, but if it did happen, and you did have an N plan, you would have to pay the excess charge. In addition to that, we have 2 copays. Every time we see a doctor, we're subject to a $20 copay, and we go to the emergency room, unless we're admitted to the hospital, we're going to have to pay a $50 copay. All right, so what's the difference? On average, about $30 a month, and that could vary depending on where you live, but usually it's about $30 a month. So people that will say, hey, not really worried about the $30, I just soon have the comprehensive coverage, they'll go with the G. Others say, I'll take the $30 savings. Probably not going to have excess anyways. I rarely go to the doctor. They may lean towards an N plan. There is no right or wrong, good or bad. They're both really, really good options. You just have to decide what you're going to be most comfortable with. All right, so that's the G and the N plans as far as supplemental plans. Now, I do want to clarify one thing about supplemental plans before I move on with our last system, and that's this. When you buy a G plan, covers 5 of the 6 gaps, N, 4 of the 6 gaps, plus some copays. But regardless of the carrier that you choose, if you get a G plan from ABC Insurance Company or XYZ Company or an N plan ABC versus XYZ Company, the coverage is always the same. There's no difference in coverage. Both of those carriers are going to pay the same bills, the same type of bills, and the same amount of bills. We call those standardized plans by Medicare. Now, beyond the coverage, there's differences in premiums and rate stability and the ratings of the company. So there's variables, but coverage is always the same. And so we want to make sure you're clear on that. All right, now let's talk about this third option, which are called replacement plans or Advantage plans. Again, a totally different system. So the way Advantage plans work is this. First of all, it's a private health insurance company that has created this plan and now is going to oversee this plan and really direct your health care versus original Medicare A and B. So the first thing the private health insurance company does is they create a network of providers. Remember original Medicare? No networks. Advantage plans, always networks, either an HMO or a PPO. The third thing that's going to happen is that Medicare A and B gaps that we talked about, those financial gaps, that whole system goes away. We wouldn't be under that system. What you're going to be under is a different system that is called a pay-as-you-go system. All right. Now, the majority of Advantage plans today, in fact, 2 out of 3, have a 0 premium to them. Now, you still had to pay Medicare, but a zero premium to the insurance company. Why? Because now we pay as we go. All right, so just give you a couple examples. There's probably 40, 50 different copays, part of the Advantage plan, but I just want to highlight a couple so you get it clear that, number one, they're not really unreasonable, but they do exist, and so we have to be aware of that. So if I go to the hospital on the Advantage plan, it costs me $350 a day. And they always set a limit. Your plan may be a 5-day limit or 6 or 7-day limit, but once I've hit my limit, I'm done for out-of-pocket for that stay. Now, if I go back in the hospital a month later, 2 months later, I'll have to pay again, but it's a daily copay that covers every service you receive that day. All right, $350 a day. Now, a specialist copay, usually around $50. Now, you can usually see your primary care doc for a zero copay. It's one of the zeros, but specialists usually about $50. Scans, this would be your MRIs, your CAT scans, your PET scans. Every time you need one of those scans, you'll pay a copay of about $250. Now, when it comes to outpatient surgery, again, knee replacements, cataract surgery and per eye would be $300. Very reasonable. Everything's covered. The surgeon, the anesthesiologist, the nursing services, the facility fee, any medications, all that's covered by your $300 copay. And then we have durable medical equipment. This would be CPAP machines, oxygen equipment, scooters, wheelchairs, walkers, those kinds of things. 20% coinsurance you pay, and then skilled nursing facility. They usually waive the first 20 days, and then after that, if we're still in, we pay about a $200 a day copay. All right, so it's a copay plan instead of gaps in original Medicare. Now, the copays will stop eventually because every plan is required to establish what we call a max out-of-pocket. These are annual amounts, and so HMOs are normally $3,000 to about $4,000 a year max. PPOs are going to be anywhere from $4,000 to maybe $7,000 a year. Go out of network, maybe $10,000 to $12,000 a year. But the whole point is there is a max. You're not going to spend $100,000 or $200,000. They'll set a max for that year, and then it'll reset. Then every January we start paying copays again until we hit the max. Now let's go and do a comparison, because folks, really what it boils down to, I hope you see that A and B is just simply too risky if you just had A and B only. And so most of you watching this are going to do either supplemental plan or Advantage plan. Let's compare those two systems real quickly. So number one, they do have one thing in common, and that's I have to be enrolled in A and B to get a supplemental plan. I got to be enrolled in A and B to get an Advantage plan, which means what? I have to pay my premium for Medicare B in either one of these systems, that $174.70 or above if you're considered to be high income. That's, frankly, the only thing they have in common. Everything else is going to be different, sometimes drastically different. So let's look at those differences, because it all boils down to you're going to have to decide which one of these systems do you want to use for your Medicare. So the first issue will be networks. If you stay in original Medicare with a supplemental plan, you can go to any provider that takes Medicare, any hospital, any doctor, any surgeon. Over here, not so. You're going to have to be on a network plan. Those are called HMOs or PPOs. Now, you'll find that the HMO plans, frankly, are financially more attractive than PPOs. Your copays are lower, your max out-of-pockets are lower, your perks they throw in are richer, stronger perks. Okay, but the issue is with the HMOs, you have less choices for sure. And also, you may have to see your primary care doctor to see a specialist. They require some of them referrals. And so they're a little bit more restrictive. PPO plans are not quite as restrictive. You usually don't have to have a referral. You can go out of the network, but when you go out of the network, it could cost you substantially. If I stay in my network on the PPO plan, it's somewhere between maybe $4,000 to $7,000 max. If I go out, it could be $10,000 to $12,000 max. HMO, I have to stay in my network. If I go out, other than emergency, the plan pays nothing. All right, so that's what we're talking about. So here, we're going to have some restrictions and some limitations. Over here, not so. Let's go to the second issue, and that would be premium-based. We've discussed this. The way I transfer the liability to an insurance company is I pay them a premium on a monthly basis. I pay them whether I use services or not, but I pay them because I don't want all the liability. Over here, you don't pay a premium other than to Medicare, but you will pay as you go. We saw the example of the schedule of copays that you'll pay until you hit the max out of pocket. And I share this with you because so many people, when they see the advertisements of the Advantage plan, think that everything's zero. And that simply is not true. You pay as you go. There's a few zeros for sure, but the majority of things you'll be paying for. Now, when it comes to policies themselves, you're going to notice here the length of the policies, the type of policies. So supplemental plans are noticed written for a lifetime. So as long as you pay your premium, that insurance policy, that supplemental plan G or N, whatever you buy, can't be canceled by the insurance company. Pay the premium, it's yours for life. Okay, it's guaranteed renewable. It's also portable. So if you live in Denver, Colorado, and you want to move to Nashville, Tennessee, take the supplemental plan with you. They can't cancel because of your relocation. They can't cancel because of age, or can't cancel because of claims. Only non-payment premium. Now, the way it works on Advantage is they're not lifetime. They're 1 year at a time, and they're very fluid. Plans come and go. Networks change on an annual basis, so things change with them. It's just an agreement for 1 year between the insurance company, you, and Medicare. That's it. All right. Now, they're not tied to you either. They're tied to a service area, which could be multi-county, could be a metropolitan area, could be half a state, but it's a service area. And if you leave that service area, you have to get a different plan. I can assure you, live in Denver, move to Nashville, those plans are different. You have to get a new network, new doctors, and all those kind of things and make those decisions. So they're annual plans. Number 4. Notice this when it comes to supplemental plans. They are very good insurance, but they have little to no perks. Every now and then we'll see a company maybe throw in a perk, maybe a free gym membership or something, but supplemental plans are just premium insurance, right? No perks. When it comes to Advantage plans, what happens is they have a variety of perks. Typically give you a gym membership, either Silver Sneakers or Renew Active Network. If your gym's in the network, go there for free. They'll give you typically a dental allowance, anywhere from maybe $1,000 or $2,000 a year for dental allowance. Hearing aids can be covered by Advantage plans. Over-the-counter cards you usually come with Advantage plans, where you can get just over-the-counter items once a quarter, maybe $50 or $75 a quarter. So the point is they have these perks that come with the Advantage plan. And by the way, the perks are fine. 2 things about them. Number 1, find out how they're going to work. Do you have to go to a network provider or not? And then how do you use the service? Do you pay for it, get reimbursed, or will the provider actually bill for it? So you got to find out the details. My one plea to you is just please get an Advantage plan because of the perks. You have to make sure you're also comfortable with the way the insurance is going to work. All right, so let's talk now about number 5, and that's this. There's no pre-authorizations with supplemental plans, and there will be pre-authorization when it comes to the Advantage plans. In fact, about 72% of the services will require a pre-authorization. So what's that mean? Well, this is an expensive service. This could be a CAT scan or MRI or a PET scan, knee replacement, hip replacement, skilled nursing stay. All these things are expensive. And so what happens on the Advantage side is the insurance company requires that they have the final say-so, their final approval. So doctor makes a recommendation, submits the paperwork to the Advantage plan, and they have to decide, are we going to approve it? Sometimes they do, but sometimes they delay it, and sometimes they just flat deny it. And people don't get some of the services that they really should be getting. And this is probably one of the biggest issues today that people complain about Advantage plans, is the whole pre-authorization process. Doctor does not have the final say-so. With a supplemental plan, you'll never see it because it's not possible. If Medicare says they're going to cover a service and your doctor says you need the service, end of story. The supplemental plan cannot intervene in any way. Medicare pays. They have to pay based upon the supplemental plan that you bought. All right. And then fourthly here, standalone drug plans are what we use if we have a supplemental plan. Standalone means a separate drug plan that you chose based upon the meds that you take, the pharmacy you want to go to. And those can be changed annually if necessary. Advantage plans actually integrated plan. They include it's part of the package. Remember I said those people, there's some that can get one without Part D, VA, TRICARE, FEHB. But if that's not you, you want to get a drug plan included. It's integrated. And so what happens here is the Advantage company actually picks the drug plan for you. And frankly, sometimes they're very good and sometimes they're not so good. But you have to make sure your meds are covered well by the plan because you didn't pick it. You have to take whatever they're going to offer you. And then lastly, very, very important to note this, and that is when you first go on Medicare, whether that's at 65 or at 67 or 68, doesn't matter. Whenever you go on Medicare, you're going to have a B date. Remember, A is inpatient, B is outpatient. And so sometimes people do A only. Remember, no HSA, it's fine to do that. And then they pick up B at a later date, maybe 3 years down the road. Sometimes people start A and B at 65, but here's my point. Once we have started our B, we have entered into a once-in-a-lifetime opportunity where we can get any Medigap policy, any supplemental plan, any letter, any company that's sold in your area, typically zip code, and you can have that plan with no underwriting whatsoever. The company has to approve the policy and issue that Medigap policy, but that window of opportunity is 6 months of your B date. So let me explain. Let's say my B date was 7/1 this year, 2024. I actually can apply for a Medicare supplemental plan along with Medicare about 3 to 6 months in advance. It's fine to do that. But once my B date starts, in this example, July 1, this 6-month window is open, and I still can get any Medigap policy of my choice, any company, any letter, no underwriting required. So in that example, it'd be all of July, August, September, October, November, December. But after that, January 1 on, if I want a supplemental plan, now I have to medically qualify in every state but 4. New York, Connecticut, Maine, Massachusetts do not have this rule. They have open enrollment year-round. But all the other states, after that 6-month window is over, now to get a supplemental plan, you have to medically qualify. I'm going to ask you 30 health questions. Check all your medications now in the last 2 years and get a statement from your doctor. And that information is given to the insurance company, the supplemental company, and they have the right to deny you or accept you. It's totally up to them. You're beyond that 6-month window. So very important time you don't want to miss out on, especially if you have some health issues. And then lastly, when it comes to Advantage plans, about switching them. Here's what happens. Let's suppose someone starts an Advantage plan at 65, and they stay on that Advantage plan for a year, 2, 3, 4, 5 years, and then they want to get off the Advantage and go back into this system. They can do so two separate times of the year. They can do it October 15th to December 7th. They can do it January 1 to March 31 every year. Okay, so we have 2 opportunities, but here's the issue. To make that switch, now you have to medically qualify to move from Advantage over to a supplemental plan. We're going to ask you 30 health questions, check your medications, get a statement from your doctor, again, given to the insurance company, and they have every right to deny you. And so what happens is people like to make that switch, and now they've had a health problem, spinal stenosis. You're not switching. Rheumatoid arthritis, you're not switching. You have AFib in your medical records, 1 incident AFib, you're not switching. COPD, certainly not going to switch. Anyone that has had cancer in the last 36 months, sometimes up to 60 months, you're not going to switch. A diabetic that takes more than 50 units of insulin a day or has any diabetic complications, retinopathy, neuropathy, not going to switch. So the point is people get in these plans thinking they can just move over real easily, and you can't except in those 4 states, New York, Connecticut, Maine, Massachusetts. Everywhere else, you're going to have to medically qualify to make that switch. All right, so we want to make sure you know. And you're going to notice that agents push these. And I'm going to tell you why they push them, because these pay us higher commissions and they pay us longer commissions. We get lifetime residuals on these. These pay well, but they don't pay as good as this. So a lot of agents really want to push this because why? They're chasing the commission. And we don't do that to our clients, and others in this business who are ethical don't do that. We want to give you all the information because you have these options that you have to live with the consequences of your choice. All right, let's start wrapping this up by talking about the Part D plans. Remember, we have either a separate standalone drug plan or an integrated drug plan. The rules apply in both systems. So these are the components of all Part D plans. Number 1, there will be a list of medications that are covered by the plan. We call that the formulary, and it's the most important decision you make because you want to make sure your meds are covered by the formulary. Number 2, within that plan, there will be some pharmacies identified as preferred and some as standard. Now, preferred is going to offer you a better price, so we always like to make sure we can find a plan where the pharmacy you want to go to would be preferred so you can save money. Then number 3, when it comes to switching plans, and the reason they allow this is because sometimes people are on a plan and then the next year they're taking more meds or less meds and they need to be on a different plan. So every year without any underwriting between October 15th and December 7th, you can select a new drug plan. And so the drug plans are a counter to your plan, but if we're going to switch, we must switch between these dates and the new plan goes into effect January 1. And then fourthly, and this is really the most confusing part of Medicare, which is going to go away in 2025, but we still have it for this year. So let me explain. We have what we call 4 phases. And these phases just simply means you could be on one medication that could change prices over that year 4 different times. So that's why we say we have fluctuating copays when it comes to Medicare plans. Now, the group plan you're on or the individual plan you're on doesn't have 4 phases. It has 1. And that phase is just typically a copay that you're paying based upon the tier of the medication. So on a group plan or an individual plan, if it's a tier 1, you may have a $5 copay and it's $5 all year long. You could be on a tier 2 that's maybe a $25 copay and it's $25 all year long. Not so with Medicare plans. They fluctuate. They're not going to be fixed year long. All right, so let's go through the phases. Now, before I show you this, I want to clarify something. It's very important to note this. How does this whole Part D system work? Well, you're going to notice there's actually 4 payers in every Part D plan. You are the patient or the one who enrolled in the plan, and then you have insurance. That's the Part D plan, whether it's standalone or integrated. And then we have Medicare that pays some of the expense, as well as the manufacturers required to give discounts. And so the point is we have 4 different participants in the cost of these medications. So let's go through them. I'll show you where you fit in here. Now, the first phase is called the deductible phase. Now, I want you to know many people do not even meet their deductible. They're on no meds or very low-cost meds, and so they never meet the deductible. But here's what I want you to realize. In this stage, you, the patient, are 100% responsible. So if that medication costs $4, you pay $4 for it. If that medication costs $400, you pay $400 for it. Whatever the cost is, because that cost is being applied to the deductible. And again, if you're on low-cost meds, you'll never meet the deductible. And if that's your situation, you will stay in phase 1 the whole year. But if we happen to be on expensive medication, then we're probably going to meet that deductible at some point in time. And once we have met the deductible, then we're done it in phase 1 and we go to phase 2. Now, phase 2 is very similar to what you're on a group plan. You just simply have copays based upon the tier of the medication. And so these are very reasonable, usually anywhere from $5 to maybe $45 copay. But here's what's different. While you're in this particular phase 1 and 2, Medicare is tracking the retail cost of your meds. You're not paying the retail cost because here you're paying a copay, but your Part D insurance plan is paying the difference up to the retail cost. But Medicare is tracking that whole retail cost. And so they set a threshold for the retail cost in this stage. This year, that's $5,030. Now listen, 90% of all people never hit that threshold. Only 10% do. But if I hit the threshold, what that's saying is they're tracking the retail cost. And that total retail cost just keeps climbing. Every month I get my medication. So it's increasing. But if it ever increases to the place where it reaches a threshold, retail, then I will be done in phase 2 and I go to phase 3. And again, about 10% of people will hit the threshold. Now, if you're on I have a guy the other day is on a medication that's $16,000 a month. Well, he reached that $5,030 in just over a week. And then he moves on to phase 3. Again, most people don't. But if we ever reach it, we're going to go then to what's called the coverage gap by Medicare. Layman's terms, we call it the donor hole. And so in the donor hole, it's a whole different system. But now what we have is a fixed copay of 25%. So I pay 25% of the cost. What's happening then, the manufacturer has to discount that medication 70%, and the plan pays 5% in the donor hole. And so what I want you to know, though, they have a whole nother number. Remember, that was retail. This is called true out-of-pocket. So that $8,000 is 70% manufacturer discount is applied into that, and your 25% copay is applied into that. So what does that mean? If someone gets the donor hole this year, what are they spending? About $2,000 out of pocket. That's it. Okay, so that is not out of your pocket because that manufacturer discount is credited in this particular phase. And then if we ever hit that $8,000, they say 1 out of 100 people will. We go to catastrophic, and because of the Inflation Reduction Act, it will be a 0 copay for you once you're in catastrophic. And so what they're saying this year, Medicare is, they're saying that when someone's on a Part D plan in 2024, the most they should spend out of pocket all year long is $3,000, about $350. That's it. Even if your meds are real expensive, you'll spend no more than that. Now, the majority want to get close to that, but those with high meds, it's capped out at that. 2025 gets better because, number one, we have a deductible. Again, you're 100% responsible for the deductible. Then you go to phase 2. You have copays, but notice those copays will stop once you have spent $2,000 out of pocket. So it totally will be capped at $2,000 from 2025 moving forward. So those are the phases. Now, I want to make sure you know the donor hole is eliminated. Catastrophic is still going to be 0. All righty, now we've seen all of our options. We have A and B only, A and B with the SUP, or we can get A and B replaced by the Advantage plan. Lots of options. So I want to explain to you, if you decide you want to do business with us, which would be thrilled, of course, here's how we do business. We are independent brokers on purpose. You can do business with a captive agent. That means they work for one company. Or you can do business with an independent broker. We've chosen to go that route because one size doesn't fit all. So we bring to the table lots of options. We write for most of the insurance companies. So we're going to look at those companies so you'll be able to choose the best company and really plan for your situation. We truly can approach it in an unbiased fashion because we're independent. Number 2, we'll give you all the initial guidance that you ask us to give you. Some people want us to help them enroll into a myssa.gov account. Happy to do that. Others ask us to enroll them into A and B. Again, we'll do that for you and with you. Some people are wanting to start Social Security at the same time with their A and B. We know how to do that as well. And so whatever you want, we'll walk you through the whole process from A to Z. We're there to help you with these things to make sure it's going to be done correctly. And then after we've set everything up correctly, now you're a client, so we give you ongoing support. Sadly, right now, most people that have a customer service problem are going to call an 800 number, and almost always it's going to be transferred to an international call center. You're going overseas, China, India, Philippines, someplace where sometimes you can't understand them very well, and I think, frankly, they don't understand Medicare very well. So our clients never have to do that. You can call an insurance company direct, but because we're your broker, we can also help you. We have the right to do that if you want us to, and so we give ongoing customer support. And so when you have a problem, you call us. And English is our first language, and we understand Medicare very well, so we'll help you solve any kind of problem that you would ever encounter as our client. And then number 4, the good news is there's no cost whatsoever for our services. Now, we don't work for free, but we're not paid by you at all. The insurance company always pays the agent. And so if you were to call an insurance company direct or you were to use us, the price to you is always the same. The insurance companies set the premium, and they always pay the agent. Again, whether it's a captive agent or a broker, they always pay us. So we're truly at no cost to you. And we believe that we bring to the table, number 1, a good education, but also lots and lots of options. And we'll go guide you through the entire process for enrollment, picking out the right insurance plans, the very best coverage for you, whether that's a SUP, whether it's Advantage, drug plan, all that we'll do with you and for you to make sure that when you go on Medicare, you're confident in those Medicare choices. Why does it matter? Because you have to live with the consequences. And we want to make sure that you're very happy with that decision. As you can tell, there's a lot to this decision on Medicare, and it's very important that you make the right one. And it really would be our privilege to assist you in the entire process. And so there's actually 2 ways in which you can reach out for our help. Number 1, you can go on the screen here and you can set up an appointment, pick a time that's going to work for your schedule. Or secondly, you can actually call the 800 number that's appearing on the screen right now. Reach out to us Monday to Thursday, 7 to 7, Monday to Friday, 7 to 6 Central Time, and we'd be thrilled to assist.